A woman has Alzheimer's for 15 years. For years, she does not respond. She does not recognize her daughter. She does not recognize anyone. Then, minutes before death, she starts a normal conversation. That is the claim. Not from a horror film, not from a religious pamphlet, from a medical review. The paper does not give her name. That matters. You do not get a cinematic identity. You get something colder, a clinical anomaly. This is called terminal lucidity. It means a person who seemed mentally gone becomes clear shortly before death, sometimes for minutes, sometimes for hours, sometimes for days. Then the person dies. And this is the problem. If memory lives only in damaged tissue, why does memory return when the tissue is failing? The case appears in a 2012 review by Michael Nahm, Bruce Greyson, Emily Williams Kelly, and Erlendur Haraldsson. They describe an elderly woman with Alzheimer's disease. She had been ill for 15 years. Her daughter cared for her. For years, the woman was unresponsive. She showed no sign of recognizing her daughter or anybody else. Then, a few minutes before she died, she started a normal conversation with her daughter. The daughter was not comforted in the simple way people imagine. She was confused because the person in the bed had been gone for years. Then she came back. Then she died. That is the first number. 15 years of disease. Years without recognition. A few minutes of clarity. This is not proof of an afterlife. It is not proof the brain is a radio. It is not proof consciousness floats away from the skull. That is the cheap version. The real version is harder, because it does not give you an answer. It gives you a failure point. Terminal lucidity asks one question. Was the person gone, or were they unreachable? That question is not poetic. It is neurological. In dementia, the brain changes physically. Neurons die, synapses fail, networks break. The systems that support memory, language, attention, and recognition deteriorate. So when a person with severe dementia suddenly speaks clearly, you have to explain the mechanism. You cannot just say, "The brain did it." That is not an explanation. You have to say, how. Nahm and Greyson first used the term terminal lucidity in 2009. They reviewed reports of unexpected mental clarity and memory shortly before death in chronic schizophrenia and dementia. They found 81 case references. They could retrieve 49 reports. Most were old. Most came before 1849. That is a weakness. Old case reports are not modern trials. They are not EEG recordings. They are not MRI scans. They are not controlled data. But they are not nothing. They are a repeated medical observation that almost disappeared from serious attention. In 2012, the larger review widened the field. Terminal lucidity was reported not only in Alzheimer's disease and schizophrenia, but also in brain abscesses, tumors, meningitis, strokes, dementia, and affective disorders. The review identified 83 cases across roughly 250 years of literature. Again, that does not mean 83 proofs. It means 83 reports of the same pattern. The mind returns near death. The return is brief. The mechanism is unknown. And the authors were careful. They admitted some accounts may contain retrospective embellishment. Some may be coincidence. Some may be distorted by memory. That is exactly why the topic matters. If you remove the weak cases, the question still remains. Why did physicians, nurses, caregivers, and families keep describing the same thing? In 2019, Alzheimer's and dementia gave the field a cleaner, modern label: paradoxical lucidity. This means unexpected lucid communication in people assumed to be non-communicative because of progressive dementia. It is broader than terminal lucidity. It does not always happen right before death, but terminal lucidity is the most extreme version. The word paradoxical is doing real work. The lucidity appears where the model predicts impairment. The patient is not supposed to have access. The disease is too advanced. The communication should not return. Then it does. And when you see that pattern, you have two bad options. Option 1. The reports are wrong. Families exaggerate. Caregivers misread reflexes. Grief turns a few words into a miracle. That happens. You should assume it happens. Human memory is not clean. Option 2. At least some reports are real. And if some are real, then something inside late-stage dementia is not as simple as total loss. Some part of cognition may be inaccessible, not erased. Some networks may be damaged, but not permanently silent. Some memories may still be present, but locked behind a system that cannot retrieve them. That is the edge. A lost file is one thing. A locked file is another. There are possible explanations. None are final. The first is fluctuation. Dementia does not always move in a straight line. Attention changes, arousal changes, sleep changes, delirium changes, medication changes, pain changes, infection changes. You may think the person is gone because you only see the worst state. Then a better state appears. But terminal lucidity is not just a good morning. In the strongest reports, the return is too sharp, too close to death, too meaningful. A person who has not recognized anyone suddenly recognizes family. A person who has not spoken clearly suddenly forms coherent speech. The second explanation is disinhibition. As the brain approaches death, normal control systems may fail. Some networks may fire in unusual ways. Suppressed circuits may briefly activate. The dying brain is not simply silent. It can surge. It can produce abnormal activity. It can enter states you do not see in ordinary waking life. But a surge is not a sentence. Random firing does not explain a goodbye. It does not explain recognition. It does not explain timing. So you still have the same problem. How does broken activity become organized meaning? The third explanation is residual memory. The disease may damage access before it destroys every trace. The library is damaged. The catalog is broken. The lights are off. The doors are jammed. But some books may still be there. Then, near death, something opens. Not enough for recovery, not enough for treatment, just enough for a final retrieval. That idea is serious because it changes how you look at severe dementia. You may not be looking at total absence. You may be looking at blocked access. That does not cure anything, but it changes the moral weight of the room. The fourth explanation is end-of-life chemistry. Oxygen falls, carbon dioxide rises, blood pressure changes, inflammation shifts. Neurotransmitters may surge, stress hormones change, metabolism collapses. One of these changes, or several together, may temporarily reorganize brain function. That sounds scientific. But right now, it is mostly a list of suspects. It tells you where to look. It does not solve the case. The fifth explanation is the one viewers will jump to. The mind is not produced by the brain. The brain is a filter. The brain is an interface. The brain is an antenna. And terminal lucidity is what happens when the filter breaks, before the signal ends. You can feel the power of that idea. You can also feel the danger. It fits too perfectly. And ideas that fit too perfectly need the most discipline. Terminal lucidity does not prove the antenna model. It does not prove survival after death. It does not prove anything spiritual. But if you watched Your Brain is an Antenna, you already know why this case matters. Orch-OR asks whether consciousness is more fundamental than computation. Terminal lucidity shows the same question in a hospital room. Not in equations, in a daughter's face. A person disappears into disease, then returns at the edge of death, then disappears again. The honest answer is this: we do not know why. And that is why serious researchers are now trying to define the phenomenon more carefully. What counts as lucidity? Does the patient recognize people? Do they remember names? Do they speak coherently? How long does it last? How close is it to death? Was there medication withdrawal? Was there delirium? Was there infection? Was there sedation? These questions are boring. That is why they matter. Without definitions, every final smile becomes terminal lucidity. Without skepticism, the topic becomes a ghost story. Without attention, the topic becomes invisible. Science needs both. It needs the cold filter, and it needs the courage to look. Because this is not just about death, it is about personhood. If a person with severe dementia can become briefly lucid, then you have to ask what was still present before the episode. Were they completely gone, or were they hidden behind damaged access? That question changes care. It changes how you speak near the bed. It changes what silence means. It changes what you assume when someone cannot respond. It does not mean every patient hears you. It does not mean every person will return. It does not mean families should wait for a final goodbye. Most will not get one. No one should be promised one. But it does mean this: when the mind seems gone, your certainty may be too strong. So here is the practical experiment. Not mystical, clinical. If you ever sit with someone who cannot remember, do not treat silence as proof of absence. Speak clearly. Use names. Use simple words. Watch for changes. Write down what happens. Time it. Describe it carefully. Do not exaggerate. Do not turn it into a miracle. Treat it like data. And if this case caught something in you, send it to someone who needs to see it. Not because it proves what they believe, because it challenges what they assume. Your brain will degrade. The networks will fail. The memories will scatter. The names may disappear. The face in the mirror may stop making sense. But terminal lucidity leaves one question behind. Not whether you will remember. What remembers you?